It would be difficult to imagine a more powerful opening for the 2025 World Medical Innovation Forum than with the conversation that you're about to hear. We are very, very pleased to be joined this morning by United States Senator Susan Collins. As chair of the Senate Appropriations Committee, Senator Collins has one of the most important positions in the legislative branch, given her jurisdiction over the entire breadth of discretionary spending in the federal government. We as a nation are fortunate that the person in that position has been a longstanding champion of healthcare and medical research. Senator Collins founded the Senate Diabetes Caucus and led the efforts to triple funding for diabetes research. She also founded the Congressional Task Force on Alzheimer's Disease and has fought for increased funding in that field. And relevant to what has been happening of late, she has been a strong voice speaking out against cuts to the National Institutes of Health. Senator Collins is in her 5th term in the Senate representing the people of Maine. Joining her on stage this morning will be my esteemed colleague, Dr. David Brown. Dr. Brown is president of the Academic Medical Centers for Mass General Brigham and is also the Mass General Trustees Professor of Emergency Medicine at Harvard Medical School. He's not only a highly respected administrator and clinician, but also a recognized leader in the field of education and also as a mentor. I greatly look forward to this exchange and welcome Dr. Brown and Senator Collins. Thank you.
Thank you, Dr. Del Carmen, and welcome everyone. Most importantly, welcome Senator Collins. I understand that you never miss a Monday in Washington while the Senate's in session, so we thank you so much for making a special exception to be with us this morning. This room is full of people who are deeply interested in what you have to share with us on a number of important topics. So as Dr. Del Carmen said, of course, you are the chair of the Senate Appropriations Committee, and in that role really hold the key to the funding of all of the healthcare initiatives across the country, including the NIH, which is of particular interest to so many of us at the forum involved in life science and biomedical research. So if we could, let's start with the NIH as our first big topic, if that's okay. So let's start with the overall NIH budget. The Trump administration announced several months ago their intention to markedly cut the overall NIH budget, stepping away from decades of commitment of partnership between the federal government and the life science and biomedical research community that has really, I think, positioned our country as leaders in that space for decades. So despite that, your committee recently passed a bill that would actually increase NIH funding. So how did that happen? What's next in the discussion, I guess, with the rest of Congress, and where do you envision the budget actually landing?
Well, first, let me say that I'm absolutely delighted to be with you this morning. It has been fascinating to talk with your researchers, your clinicians, your academic professors, and to see the tech hub in back of us, which was absolutely extraordinary. So thank you for the invitation to join you this morning. When the Trump administration took over, they took 2 immediate actions. One, they announced that they were going to cut the NIH budget by an astonishing 41%. That was very alarming to me. I've always been a very strong supporter of biomedical research. I've seen the cures, the effective treatments, the means of prevention that have made the difference in treating devastating diseases that affect families all over the United States. I was also very concerned about what it would mean for America's global leadership in biomedical research. And so the first hearing that I held as chair of the committee was entitled Biomedical Research, Keeping America's Edge in Innovation. And we looked not only at the impact of cutting biomedical research by such an extraordinary amount. And by the way, it wasn't just NIH. The cuts were also going to be devastating for the National Science Foundation and for many other research agencies. And at that hearing, we heard from practitioners, we heard from researchers, we heard from a little girl and her mother. The little girl had pediatric cancer, and her life had been saved by a clinical trial. Very moving, really touched people. I will never forget the testimony, however, from an individual from the state of Maine who runs the MDI Biological Laboratory in Bar Harbor. He came to this country in 1987 because he said that America was the irresistible magnet, attracting the best and the brightest researchers and scientists from all over the world. And what I was hearing is that young researchers and scientists were wondering, is there a place for them in America? Are they going to be able to pursue the research that motivates them, that inspires them? Or are they going to have to go elsewhere? And immediately we started seeing China, Japan, Germany, France, trying to take the best and the brightest. And that really disturbed me. So I saw this from two perspectives. One, what is the impact on families all over the United States if we slow or stop research in particular areas? But second, what does it mean to America's place in the world as being the global leader? Are we going to lose that? And will we lose it for generations? So I worked very hard with other members of the committee to stop the cuts. And I'm very proud of the fact that by a vote of 26-3, our Appropriations Committee reported the bill that includes the funding for NIH with not the 41% cut, but a $400 million increase. And now we've got to get it through the rest of the way. The House didn't do quite as well, but it did not adopt the 41% cut either. So we're in the zone where the fiscal year ends very soon. We have to keep government open. That is absolutely essential. But we need to keep working to bring this bill to the Senate floor. And I'm hopeful that that will happen. I know we're going to talk about indirect costs also, but that was the other big surprise.
Indeed it was. Well, this whole room is rooting for you in the next stage of that bill.
Thank you.
So sticking with the theme of NIH, and we'll get to indirect costs in a minute, but I want to talk a little bit about health equity. You've been a champion of health equity, of efforts to reduce disparities in the delivery of health care, and yet the administration has taken a step away from that commitment. We've seen grants canceled, many in mid-enrollment. Is there still an energy and enthusiasm in the Congress for this type of research, given the deprioritization by the current administration of this issue?
It is more controversial than the overall number for the budget for NIH, but I think that's because we need to educate people about health disparities in particular. I divide it into two categories. When I think of health equities, I think of the authority that the Secretary of HHS has to award grants that will deal with housing, with food insecurity, with factors that affect people's health. We just had a bad breakout in Bangor, Maine, where I live, of HIV among those who are unsheltered and are drug users as well. And it's a horrible breakout, the worst that we've seen. So that's an area where you can legitimately ask if there were more vouchers, if there were more homeless shelters, if there were more wraparound services to deal with the problems, would that outbreak have occurred? I don't think so. And the fact is that outbreak not only has terrible consequences for those affected, but it's also very costly. And in many ways, it's more costly than dealing with the underlying factors. There is a project going on in North Carolina that was awarded by the first Trump administration to look at housing, hunger, other equities, to see transportation as one, to see if it makes a difference not only in healthcare, but in lowering costs. And the data's preliminary, but it suggests that it does. Those kinds of projects have been canceled. Health disparities, to me, are a different issue. To me, one of the best examples that I would urge you to share with your legislators is the difference in maternal mortality rates. For Black women, the rate is, I believe the number is 12 times higher than for white women. For Asian women who are pregnant, it is lower than for white women. To me, investigating why is that is really important, because if we don't understand why there is such a dramatic difference in maternal mortality among these three groups, we're not going to be able to figure out a solution. So to me, that is very worthy research to identify why that disparity exists. And what I think the administration did is use AI to go through grants and pick out certain words. And if certain words, for example, this happened in a grant that affects our fishermen, our lobstermen in Maine. It's part of the Sea Grant program. Because it had the word climate change, because obviously warmer waters affect the lobster population, it goes further north. And, but if you had the word climate change or sustainability in the grant application, the grant was paused or frozen. Now, I helped the University of Maine and the industry reapply, and they're able to do the same thing, but use more words that aren't red flags to AI and to this administration. So you might want to think about that as you draft your grants. A lot of times you can accomplish exactly the same goals, and indeed, we were successful in getting the grant reestablished in Maine. But that's, we've talked a lot in the Tech Hub about the wonders of AI, but there's some downsides too.
Well, thank you for your advocacy in all those areas, and I'll just maybe comment on the remarks you made about the social determinants of health, housing insecurity, food insecurity, and the like. As an emergency physician, I saw the end result of that through most of my career, and we'll have a chance actually in this forum to talk more about this, actually a little bit later today when we celebrate the Kraft Award in Community Health. So you mentioned indirect costs a few minutes ago, and I said we'd come back to it, so let's come back to it. So the Trump administration announced its intention to lower the NIH indirect cost rate to 15%, a massive reduction for some organizations, many organizations. So This would have enormous impact on biomedical and life science research across academic institutions across the country. What was your reaction to that, and what role will your committee have in getting us to a resolution? It's, of course, in the courts right now.
I was shocked. First of all, one size does not fit all, and this was an arbitrary 15% cap that was applied across the board rather than the negotiations that occur between NIH or other scientific agencies and the grant recipient. So this came out of the blue, but I was shocked for another reason. In our appropriations bill, we had specific language that prevented the administration from changing the way indirect costs were applied and calculated and negotiated. So this should not have happened, which is why it is in court now. Having said that, we do need to have more transparency, more accountability, and work toward lowering the administrative burden, as your CEO has mentioned to me, of indirect costs. So they're not perfect. What we did is we covered this in the hearing that I held, but we're also working with Calvin Drogenmeier, who many of you may know was the science advisor in the first Trump administration. He has gathered research institutions, academia, universities that do a lot of research, independent labs, I mean, everybody who's interested in this, and they have come up with a new model that's called the FAIR model. I always sort of bristle at the term indirect costs because they're more accurately called research-related costs, and that's what we should refer to them. A lot of the indirect costs enable the research to be done. What I found is there was tremendous misunderstanding in the Congress that the OMB in some ways did not correct, that the indirect costs were subtracted from the research grant. Well, you all know that they're additive, but what people were saying to me was, by people I mean my colleagues in the Senate, were saying to me, but Susan, you're lowering the amount that's actually going to research. You're not, you're enabling that research. However, the system is very complicated. And I think this new model, which has been developed by this group called the FAIR model, would make the system less opaque, and it would classify, as private foundations do, more of the indirect costs as research, direct research costs, which they are. In a lot of these cases, you can't do the research if you don't have somebody who's being paid to enroll people in the clinical trials, do the paperwork, reimburse them for travel expenses. There's also a big difference in the associated, the research-related costs between a clinical trial and an early stage research project that may be primarily just in a lab with, not just, but located in a lab. So they should differ from grant to grant. And that's something that we would do with this new proposal. So how is it going to come out? In the meantime, as this is being put together, we put in placeholder language to prevent changes, but that's not going to work. We need an alternative. This is a good alternative. And what I would caution all of you, every academic whom I've talked with has a great tweak for the proposal that Calvin's group has come up with. We don't have time for that. We need to coalesce behind him, because otherwise, as soon as the fiscal year expires on October 1st, OMB is going to start rulemaking on the 15%. They've met, to their credit, with Calvin, as have all of us, and we've all have been advocates for coming up with something other than the cap, but they don't like that it isn't saving enough money from their perspective. So we can't have 1,000 different ideas out there. We can't have 20 different ideas out there. We've got to have everybody coalesce behind the JAG idea, the FAIR model. That's not to say that it's perfect, but otherwise we're going to end up, I fear, with the 15% across the board cap.
Well, that's a cautionary tale for this group and something that we'll certainly take back. I fully agree with you that there's an opportunity here with more transparency, more attention to efficiency on the non-research facing part of the research budget. A middle ground here that won't dismantle our research programs is essential, and thank you for leading that effort.
Thank you.
So let's take a few minutes and talk about Medicaid. So for decades now, there's been a really productive partnership between the federal government and state governments to ensure that the healthcare needs of our economically disadvantaged population is met. And yet, with the passage of the big, beautiful bill, the federal government is taking a significant step away from that commitment. So first, you were one of the very few Republican senators in Congress to vote against that bill. And at the same time, you were instrumental in getting that large placeholder in place, the Rural Transformation Fund of $50 billion. How did you make that happen? And second, how do you envision those dollars being spent? And do you think it's enough to offset the impact on our patients, on our community?
Well, first let me say I am really concerned about the impact of the Medicaid cuts, not only on the recipients, but on our healthcare system, particularly our rural hospitals. In a state like Maine, which is a low-income state, and it is a state that it has mainly rural hospitals, Medicaid is the number 2 payer. Medicare is number 1, Medicaid is number 2. So in Maine, a state with a population of 1.3 million people, 400,000 people rely on the Medicaid program for their health care. So it's almost a third, it's about a third of our population. And these cuts, I worry, are going to be devastating for states like Maine, for the people who rely on it. But you know, a lot of those individuals are still going to show up in the hospital emergency room. They won't have been getting the care that they need to keep them out of the hospital emergency room. They're going to be coming to you with their problems, and they're not going to be covered by Medicaid. And the problem with that is it's going to be uncompensated care for hospitals. And we have 5 rural hospitals in Maine. We just recently lost one. We have about 32 in total. We have 5 that are teetering on the brink of closure because they're already in trouble because the Medicaid reimbursements are not high enough. And also because of population changes, and Maine is the oldest state in the nation, which doesn't help. So a lot of chronic conditions, a lot of need for health care, a shortage of healthcare providers. And I, from the beginning, said to the White House officials, said to the leaders in the Senate, that I could not support the big, beautiful bill, despite my support for many of the tax extensions that were contained in the bill, as long as it had these deep Medicaid cuts. And in the end, by the way, the Medicaid cuts are more than $900 billion. Think about that. And they don't go into effect next year. They go into effect the following year. But a year is not going to make any difference at all. And I'm just very concerned that people who need the care aren't going to get it. Now, there's some reforms that I supported. I think if you're an able-bodied adult who is able to work, that having a work requirement is not unreasonable in any way. But these cuts go way beyond that, way beyond that. One of the provisions that I'm about to introduce a bill on that bothers me the most is requiring children with severe lifelong disabilities to have to re-register every 6 months to qualify for the Medicaid program. That makes no sense whatsoever. And I've seen that firsthand. I had some families from Maine come to Washington with children who were severely disabled. And I hope there will be miracle cures for them, but the likelihood is that they will be disabled for all of their lives. Well, one of them was a single mom who's working full-time. She's going to school to try to get a nursing, a CNA degree. She's trying to take care of her severely disabled son and her other children. I don't know how she does it. Well, requiring her to have to worry about whether she filed the paperwork on time to make sure that her severely disabled son is able to get the health care he needs, or also relying on an overburdened healthcare provider in Maine that has a huge practice in a small town, not to miss the deadline for verifying that this child has a lifelong disability. That just strikes me as cruel and totally unnecessary. So I'm going to be shortly introducing a bill. I'm working with the group called Anchor, which some of you may have heard of, and they do a great job representing people with intellectual and developmental disabilities. And I hope we can get that changed through. But I did from the beginning, I actually did a list of 10 items that I needed changed in the bill. And I gave it to individuals at the White House, I gave it to the leaders of the Senate, the leaders of the committees involved in drafting the bill. And I said right from the beginning, if these aren't changed, I can't be there. One of them was to add a rural hospital relief fund. Now, what many people don't realize is back in 2003, when we were doing George Bush's tax cuts, I added to that bill a rural hospital relief fund, and successfully so. So eventually, a $50 billion rural hospital transformation, they changed the name of it, fund was included in the bill. That will certainly help, but it does not begin to completely offset the cuts in the Medicaid program. But it should buy us some time, and I'm going to be working with Dr. Oz and encouraging him, he's the administrator for the fund, to get that money out as quickly as possible. And the awardees of your craft prizes, plus what I saw at the Tech Hub, are ways that we can transform medical care and make it more efficient. And it's particularly important in rural areas like the state I represent. But really, all over America, there are rural areas.
No, there certainly are. You know, your comment about the percentage of Maine residents who are supported by Medicaid is not that different than in Massachusetts.
Really?
Very close, yeah. So you identified the two major threats of the reduction in Medicaid funding. The first, of course, is to patients, making it hard for patients to re-enroll who would be eligible, making it harder for patients to get primary and scheduled preventive care. And the second big impact is going to be on the hospitals and healthcare systems that are still, as you pointed out and correctly, still have to take care of patients and want to take care of patients regardless of whether they still qualify for Medicaid. Given the expected negative impact on public health of this bill overall as it rolls out, and as you point out, we won't feel the full impact until 27 and 28, but in the event that there is that negative impact that we fear, do you think there'll be an opportunity either at your committee in Congress or at the White House to revisit this and think about mitigating legislation or appropriation to try to support this community of patients and, of course, the healthcare systems in America?
So the area that I do not have direct jurisdiction over is Medicaid, Medicare, and Social Security. That's in the Finance Committee. I have jurisdiction over what is called discretionary spending, which is why that includes NIH. I don't see the states having the ability to step up and fill the gap here. I just don't. Even wealthy states, I just don't see that happening. And as the implications of the bill become better known, I think there's going to be tremendous pressure on Congress to change the law. But we're going to need the evidence, the stories, the research that didn't occur when getting back to NIH, although I really am optimistic on NIH, but people who didn't get the care in time because they were diagnosed only when they show up at your emergency room rather than by a primary care physician. So if we start seeing Americans getting sicker as a result of this, having delayed treatment because they no longer have the coverage, and if it's combined with changes in the Affordable Care Act that also would restrict coverage or make coverage more expensive to get on the exchange, then I think you will see a lot of pressure to take a better look at this. This doesn't mean, however, that we shouldn't look at ways to reduce the cost of healthcare. Medicare and Medicaid are going through the roof. I mean, the costs are extremely high. To me, the answer is found in a lot of the technology that I've seen, in appropriate use of AI, of reducing some of the administrative burden. When I learned there are more than 150,000 codes that many insurers use, no wonder physicians and other healthcare providers are so discouraged by the paperwork that they have to go through. And we see that on prior authorization. We see that on CMS being very slow to approve the 2 new drugs for Alzheimer's that have been shown, if administered early enough, to slow cognitive decline by some 30%. That's amazing and would have huge cost implications, not to mention the impact on people's lives and their caregivers and family members.
Well, thank you, Senator, and you did sneak ahead to a topic.
Sorry.
No, that's good, because we may not have time to get your thoughts on healthcare costs writ large, and you gave us a preview, at least, of your thinking about harnessing technology to reduce the administrative costs and make ourselves more efficient, which we certainly must do. But let's take a moment and talk about vaccines. So you've been a longtime champion of vaccine research and development, and that has paid benefits for the American people in many, many ways. In the first few months of this administration, though, we've seen cancellation of mRNA research funding, and we've seen the dismissal of key members of committees that advise the federal government on vaccine policies. What's your reaction to this approach? How much concern does it bring you? And what are the steps forward for all of us?
I oppose Secretary Kennedy's move to fire all the members of the Independent Advisory Board on Vaccines. I believe that's going to lead to less independent and less professional recommendations. When I read that the state of Florida has lifted its vaccination requirements for school children, I am really worried that we're going to see outbreaks of measles. It's already happened in Texas, in this country, totally preventable outbreaks of measles. I remember talking to a pediatric nurse practitioner in the state of Maine, and she was talking about children in the school who have autoimmune diseases that prevent them from being vaccinated. And she said, if you don't create that herd immunity by the rest of the children being vaccinated, you're compromising their health. And I always thought that was a great example. And I was so grateful for my conversation with her. And I've used that many times. The CDC, the firing of the CDC's director, Susan Monterez, who I've dealt with extensively. And she called me. We discussed her imminent firing. I called her after she was fired. And she was on the job less than a month. She is a very well-respected scientist, and 4 of the top CDC people resigned in protest. And I talked with one of them just last Friday, and she has been at the CDC for 11 years. She is well-respected all across the globe. And Susan put it best to me. She said that she was asked to fire all these people and refused to do it. She was asked to rubber stamp recommendations that she disagreed with vehemently on vaccines, and she refused to do that. She is a person of great integrity. The good news is that this Wednesday, Senator Cassidy, who is a medical doctor himself and is the chair of the Health, Education, Labor, and Pensions Committee, is holding a hearing with Susan, with one of the top deputies who was fired. So we are going to be able to probe this in public, in depth. And I give him huge credit for holding people accountable and for having this hearing, which follows the hearing the week before the Finance Committee that Secretary Kennedy testified at. So in Maine, at the Maine Medical Center Research Institute, and I discussed this vaccine with Secretary Kennedy at his nomination hearing. There is research going on for a Lyme disease vaccine. It's always struck me as ironic that my dog can get a Lyme disease vaccine, and we do give it to her every year, and I can't. And there was one briefly on the market that was withdrawn. But I'm really excited about this research because in Maine, the number of people diagnosed with Lyme disease has soared in the last 10 years. We have ticks all over the state now. They just used to be in the southern, warmer part of the state. Now they're everywhere because of changes in the climate and other factors, but they are everywhere. And having had, but I knew enough to recognize it, that bullseye rash one summer, and I instantly called the doctor on call and got on the antibiotics. But I'll tell you, there are so many people. So we've had a record number of 3,000, more than 3,200 cases just this past year, and I'm sure it's going to go higher. And the problem is that there's still a lot of practitioners who don't recognize Lyme disease, and not everybody has the bullseye rash. And I have a niece who's had it 3 times and has joint pain now that she's living with. And this is serious. So I got a commitment from the secretary that he will not interfere in any way with that important research that's going on. But I'm also worried about the international vaccine programs, like under the Gavi program. Those help not only the people in Africa, whom we very much want to keep healthy and prevent from getting these illnesses, it helps us. Those illnesses do not respect borders. They travel. And that's why the fact that people are going to be so confused about whether to get vaccines is very troubling. And let me say, I don't think that the CDC did everything right during the pandemic. I don't blame them for that because they were dealing with a brand new disease. And it's not surprising. I personally think closing schools caused more harm than good, but I realize there are legitimate arguments on both sides of that. The problem is the CDC did lose some public confidence during COVID, but now that's only going to be worse. And people look to the CDC for advice. It's very confusing for most people now on whether to get a COVID vaccine, whether their insurance will cover it, whether they have to have a prescription from their doctor. You don't in Massachusetts and Maine, but you're going to have to in some other states. So it's a problem.
Well, Senator, you touched on so many important issues related to vaccine research and vaccine administration. I want to ask you some more questions, but I promised your staff that you would be able to get to the airport on time to get down to Washington. And so you brought up so many other issues that we would like to touch on, and maybe there'll be another opportunity to address this group in another forum. We thank you so much for your leadership on behalf of not just your constituents, but on behalf of the entire country. All of us are patients. And of course, on behalf of the life science and biomedical research community that really is spread out across this conference hall and will be here for the next 3 days. So thank you again for being with us this morning, for prioritizing this, and for all that you do for the country.
Thank
Senator
you.
Collins.
Thank you so much. Thank you. Thank you. Thank you.